Dear all, thank you very much for this kind opportunity to present our work that was selected for publication in GI Endoscopy. The article is called Endoscopic submucosal dissection of appendicular lesions that is feasible and safe, a retrospective multicenter study. We presented a few years ago the first experience about the initial patients that were treated for neoplastic lesion invading the appendix orifice. We described all the lesions according to Toyonaga's classification published in 2016, and you know that when the lesion is far from the orifice, or when the orifice is reached but not invaded, or when there is a small invasion, it seems that the resection is feasible, but usually it was accepted that type 3 lesions invading deeply the appendiceal orifice were a contraindication to endoscopic resection, except in patients with appendicectomy. We described a few years ago a strategy to treat this kind of patient, doing a circumferential incision all around the lesion, and then fix first a monopolar traction, and after we did a multipolar traction with several points all around the lesion. The aim is to try to tract the appendix outside its orifice in order to make the resection feasible in the orifice area, and we try to go as far as possible in the appendix orifice using a traction which is stronger and stronger with time, according to the new devices like adaptive traction devices. And when we cannot go further or deeper, we cut the mucosa doing a circle, and we remove the piece, which is stretched in cork with two different parts, the circumferential part, and we do a hole in the cork to stretch the diverticular part of the appendix and to fix it on the opposite part of the cork, in order to have the circumferential margin, the deep margin in the submucosa, but also the deep margin of the appendix orifice. The results are presented here. We had approximately 1/2 of lesions that were type 3 of Toyonaga. That means a deep invasion of the orifice. En bloc resection was obtained in 83% of the cases, and R0 resection in 91% of the patient treated en bloc. The curative resection rate was in mean 78%, but 76% only in the type 3 treatment, and the risk of surgery was higher in the type 3 with a deep invasion of the appendix, because we had more surgeries, more for non-R0 resection at the deep part than for adverse events, that were in total 4.2% of surgery for adverse events and 9.8% when it was a type 3 lesion. So finally, what we can say is that the risk is low, but a little more for lesion with deep invasion of the appendix compared to the lesion with a shallow invasion of the appendix orifice, like type 2 of Toyonaga, or type 3 but on the site of a previous appendectomy. So finally, in conclusion, a neoplasia surrounding the appendix, even with a deep invasion of the appendix orifice, is not an indication for surgery in every time. We can try an endoscopic resection. Patients should know that the risk of this resection is a little higher than the risk for conventional ESD in the colon, but it is still low, with 4.2% of adverse events leading to surgery and around 80% of curative resection. So finally, using endoscopy and endoscopic submucosal dissection with traction seems safe and effective, and it could avoid a lot of surgery that are probably not totally justified for very shallow lesion like SSAP or adenomas without any risk of malignancy. We thank again GIE for choosing our work that was done in collaboration with Mariana Figueiredo, coming from Brussels for a fellowship in our city, and that lead this work with the French Society of Digestive Endoscopy and the cohort of ESD, which is prospectively maintained. Thank you very much.